Hello, this is Lynn Lucas-Fehm, President of the Pennsylvania Medical Society, and I am so pleased to have with me today our next president, Dr. Arvind Cavale. He's an internist specializing in diabetes and endocrinology, and he practices in Bucks County, which is a suburb outside of Philadelphia. He has numerous accomplishments. One of the things that I found most interesting and that I have gotten to know well about him is his background. It has to do with business. He is a physician CEO, that he got his training with that at the Kellogg School of Management at Northwestern University. Um, He's a fellow in the College of Physicians of Philadelphia, also a fellow of the American College of Endocrinology. It's just so great to have him with me today, and we're going to learn more about him as he starts his tenure as president of PA Med in 2026. Welcome, Dr. Cavale.
Thank you. Thank you, Dr. Lucas-Fehm. Appreciate you inviting me today.
So let me start by having you tell everyone about your current practice and just a little bit about how your philosophy in practicing medicine is and why you chose the modality and method that you utilize.
Sure. So I'm a clinical endocrinologist, currently in a small practice of two physicians in Bucks County, which is outside of Philadelphia, as you mentioned. So I've been in this practice since 2002, and our philosophy is essentially sort of based on our core principles, which is patient beneficence and outcomes, and an empowered team, and finally join practice. So essentially, that's how we set out. My first 3 years in the Philadelphia area, from 1999 to 2002, I worked with a group of 5 physicians in Northeast Philadelphia, large, busy endocrinology practice, great practice. But that was not the model I wanted to continue. So I went out on my own in 2002 and decided to start from scratch. And the few things that I found were from my learning from my previous practice. Efficiency matters, optimizing technology use so that not only are patients better served, but also the staff, the team members are more able to take care of our patients without too many distractions. So essentially, our core principle was always to take care of our patients, irrespective of, you know, what kind of hurdles we face. And throughout the last 23 years, we have maintained that discipline and that philosophy. Over the last 15 years, we are also a clinical research site, and our primary research has been in the GLP receptor agonist space. Um, we have participated in GLP receptor agonist studies from the first generation to the second and third generation. So we've had 3 very large long-term studies that we've participated in. We just completed one about a few months ago. So that's been an exciting avenue. So apart from this process, what I've tried to demonstrate to myself as well as colleagues is that independent practice is still possible if you have a certain core set of principles that you are abiding by all the time. So that's where we are at this point.
So looking back when you said you basically started over. Amazing. So
Yeah.
when you took that on to start over and looking back on it, what would you like to have told that former self starting out then that you've learned
Mhm.
now, to make things
Mm,
smoother? It couldn't have possibly been easy. So,
right. Yeah. So I have been sort of involved in sort of policy space for about 21 years, since 2004. So when I first started, I wish I had realized the massive impact of regulations, both state and federal, have on small independent practices. And I wish I had learned that earlier than I did. I kind of came around to it around 2007, And by that time, a lot of things had happened that I would not be able to change the course of. So I had to adapt my practice accordingly. So that was a big realization for me. A series of federal regulations, federal laws starting in 1997, 2003, 2010, 2015. These are all essentially laws that progressively crippled independent practice, and they promoted consolidation in the healthcare industry and created some sort of a misaligned incentives and forced many physicians into selling or into to the hospital systems or into private equity or retiring early, right? So, and this has really cost our patients very dearly in our communities and our nation. And so that's sort of where I would put my if what if scenario is what if I had learned about all the if impacts of all this, and how would I have changed the practice of my practice per se? Yeah.
Do you think there are some personally rewarding aspects that come with the independent practice that are really not available or achievable in a huge health system or other types of practices? Is there something you think unique and more fulfilling, not only professionally, but also personally?
Sure. So, as I said, our core principles, are still true, right? So, our ability to consistently deliver on our core principles has been, I would say, the biggest reward in terms of when I always look back and say, how painful can independent practice be? It can be very painful. But when you go back and say, okay, are we meeting our core principles consistently and effortlessly? And the answer to that is yes. And then it sort of um, get you back in the belief that you can still manage to do that, right? So knowing our patients as individuals is another factor, right? So one of the constant themes that we see in our practice is people, simply saying, "I trust you, doc. Just tell me what I need to know." It's a very simple statement, but it's probably the most profound statement that as a physician you would want to hear is for them to say, "I trust you," right? And without prompting, right? So that's something that's really important. We have built long-term relationships. Several of my patients are now in their 90s, and they were in their late 60s or so when I started seeing them, right? So these are all long-term patients. Patients also have become our marketing uh, tools, in the sense our practice has benefited from this level of trust that I would say at least half of our new referrals are now word of mouth referrals. So it's either families, friends, coworkers, strangers. People meet people in the grocery store and talk about it, and then they refer patients to us. So building these relationships has been an extremely important value for us. And when I started, it was just me and my wife in the office, and our now 24-year-old son was a few months old, maybe 7 or 8 months old, and he would be in the playpen in the front office because she would be managing the front office and I'd be in the back. And all those patients who used to see, they come and ask me, "How's the baby?" Right? The baby is this big, and so it adds to the feel of a community practice. So we feel like we are sort of the fabric of the community, and because we have stayed in the same area for 23 years, and we are at the sort of the intersection of the three counties in the Bucks, Montgomery, and Philadelphia. So we have become a fabric of the community, which is, I think, in the long run, the legacy of our practice would be that it's part of the community, right? So that's a good feeling to leave at some point.
So certainly this huge personal reward from doing it. Now, how do you manage to keep that with, and certainly you have the background to analyze it with your background from the Kellogg School of Business,
Mhm.
the economic weights that are put upon you that make it difficult for you to be able to have that practice and maintain that personal, successful relationship you have with the community. So, what are some of those impacts? And it can be in any you discuss it in any way that you want to, whether it's a personal level or whether more globally. I know you are always surprised of what goes on with large health systems, financial pressure, private equity, financial pressure. How do you work that all together? And then let's sort of weave into your presidential initiative, which is about autonomy, physician autonomy. But we'll
Right.
start with that financial impact. Walk me through how you deal with that.
So this was part of my training. So when my first day of fellowship in 97, my program director sort of brought us into the office and said, we gotta start with an oath of poverty. You're entering endocrinology, so we're gonna ask you to take the oath of poverty. So it sort of set me off with reasonable expectations as far as economics is concerned. But of course, as I told you earlier, didn't expect the massive impact of regulations economically. And as you know, that Medicare payments to independent practicing physicians have progressively declined. In fact, on a relative basis, we are getting paid less in 2025 than we were in 1997. Okay, so how do you run an operation, a business that is entirely funded through patient care and or clinical trial processes? How do you run that when there's a sequential decline in payment structure? And we always, from the day one, had promised ourselves that we are not going to be a high volume, churning patients in and out type of practice. And so we had always decided that we are going to be a slow turnover, detail-oriented practice. So from an economic sense, it didn't make any sense that we were delivering these high-level care and receiving progressively declining payments for that care. Right. So fundamentally, we were struggling for a long time financially, but we really didn't stop doing what we believed was essential and valuable for our patients. And what we tried to do to overcome that was to run a tight ship and minimize overheads, reduce unnecessary, work that did not generate revenue for the practice, etc. But those are all really fringe efforts, unfortunately. And so what we decided to do was a deep dive into utilizing advanced technology. And so my practice has been digital since 2002. So I never had paper charts since I started. It was very rudimentary in the beginning, but we decided that was money well spent, because we didn't need space to put the chart racks and all this other stuff. We didn't need people to do dictation and transcription. We incorporated all those things into technology, and we had in those days we had an e-fax that we used to use, and so we invested in some of the technologies that we still continue to invest in. And eventually we figured out that delivering superior outcomes while does provide a very good safety net in terms of revenue streams. So we didn't lose hope in the free market system. We still believe that taking care of the customer, like they say, will bring more business, right? I mean, and essentially that was really our target, is to say we'll just do well by doing right all the time, and that really continues. And we hired and kept staff members and team members who also believed in the same principles. So in fact, we have 3 full-time team members in our office, and they're all at least 10 years with our practice. And a couple of them are 20, 21 years with our practice. So we don't churn over staff members, and we don't, we're not a very high volume practice. So, and as I said, by 2010, we started to get interest from different academic centers, and and pharmaceutical agencies to do clinical research, which is a very nice segue, from our clinical practice. And initially, I was not very thrilled about it, but so we started with just one study, which turned out to be a 7-year study. And we learned a lot by making a lot of mistakes in that study. And so then once we start developing a reputation in the clinical trial arena, then people start referring new studies to our clinic, right? So then we start, so now it's 15 years of doing clinical trials, which people wonder how I manage both full-time, practice and clinical trials. And I
Yeah.
think that's just a little bit of my own sort of adrenaline that pushes me. But what I also did was very interesting is that in 2008, I decided to basically end all my in-hospital consultation work. And what I realized was that um, the hospital-based work was very inefficient and time consuming and unsatisfying, most importantly, unsatisfying, because there were too many pieces. And that was the time when most of the hospitals were beginning to digitize their records, and they started to impose, physician order entry mandates and things like that. And it was not what I believed was in the right interest of my patients. Because if I spend time at the computer desk, I'm not taking care of the patient. And same thing with the nurses, if they're spending time. And there was nothing I could do physically or personally that would change that dynamic. So almost at the peak of my career, I decided to just quit hospital medicine and focus 100% on office-based practice. And people were not very happy because at one time I used to round at 5 hospitals and do full-time office work. And I mean, I can't imagine how I would have done that, but I was young, I suppose. So
Oh,
I quit hospital work right away, and I just sent everybody a letter on December 1st, said as of January 1st, I'm done. And but actually, that gave me a new lease on life because now I had a little more time to innovate in my office arena and build new systems, new processes. And interestingly, the business school that I went to was actually relatively later in my career. It was only 6 years ago that I went to business school. And what I learned there was very fascinating. I mean, yeah, I still use all the techniques and the lessons that I learned. But I also taught my business school professors an important lesson, which was only in medicine does doing or delivering a high quality service lead to lower valuations, lower revenue, right?
oh,
Especially in chronic disease management, because that's what I'm an expert in. Because if you solve people's problems, they won't need you, and so your revenue would actually go down, right? And they wouldn't initially believe me until the end of my course when I did my presentation with my new model to say, look, this is how a model that rewards high quality care should look like, but this is the model that we have, which actually just rewards mediocre care, not high quality care. And I also showed them by throwing numbers at them that high quality care actually costs less than mediocre care in the long run,
yeah.
right? And we don't realize that. We think that high quality care should actually cost more. It doesn't. It's just the initial investment is probably higher, but when you do a long-term analysis, it actually costs less. So, and I think that's sort of part of the thought process that I'm bringing into my presidential initiative is to figure out who are our partners who recognize that high quality physicians are worth paying for, as opposed to simply paying everybody the same amount and hoping that they do a better job, right? So that's
Mhm.
sort of my kind of economic analysis of the whole
Very
sequence of
good.
events. Yeah.
And it's amazing. The movement you made was contrary to what most physicians have done in the last 25 to 30 years, which is move to large health systems. You moved the other way. Now, having done that migration, do you think that this model that you propose that is amazing in terms of patient care, But how many of our particularly younger physicians who really have grown up with the model of the big health system, and some don't even, I think there is something else to do. How do you break through to them that there is this other option? That, certainly probably won't become the majority option, but that it is a viable option.
Yeah. Yeah, so that's where I think your initiative of practice options, helps. How to position the Pennsylvania Medical Society as a sort of a platform for younger physicians, or even medical students for that matter, or first year residents, second year residents, to start thinking of independent practice as a viable option. It may not be for everybody, but the encouraging thing I'm seeing amongst those that I interact with is that a lot of the Gen Z physicians or medical students are very interested in in this model. They have my experiences, and this is very anecdotal, and I don't want to think that this is something that I have evidence for, but my observational evidence is that the millennial generation of physicians were looking at the baby boomers and saying, we don't want to be like them. And so they decided to just go into hospital employment without even looking into any other options. And they were also coming in with a lot of debt. So they figured that that was a good safety net for them. The next generation of physicians, which is the Gen Zers, are actually looking at the millennial physicians who happen to be their very near superiors in terms of seniority. And they're probably saying that we don't want to be like this generation. And in between sandwich sort of was the Gen Xers like me, who sort of had the work ethic of the boomers, but probably the philosophy of the millennials. So we kind of got stuck. But a lot of the Gen Xers actually are now sort of role models for the Gen Zers. And I feel pretty confident that the resident and fellows who are probably around 30-ish right now will look into. And that's where I think an organization like PMed can actually drive that interest further, in my opinion. And so what I'm doing is I have a cohort of third year osteopathic medical school students that rotate in my office, and they are actually from the University of New England in Maine. So they spend a whole year in the Philadelphia area, and they rotate with 6-week intervals. So we have enough time to kind of understand them and them to understand us, and to go through a lot of. So this is my second year of doing that. And a lot of them have expressed interest in independent practice, and I have been able to introduce them to different PA Med members who are still successful independent practice physicians. So it's been a nice, fresh, actually, experience for me that these younger folks, students actually, are interested in especially the primary care track physician, medical students who want to do either pediatrics or family medicine. They are very, very interested in models like direct primary care or any kind of direct care model. And we have in our area several younger physicians who are within 5 years, early career physicians, let's say, who have moved out of conventional primary care and gone to direct primary care. And I know at least 3 docs in our area have moved in that direction, which is very encouraging.
Very good. So
Yeah.
let's wrap it all up and make sure that I haven't left anything out that you feel you would really like to say to people watching this, about your initiative, about physician autonomy, about, let's bring it all together and tell me your message.
Oh, okay. So I have studied, the three previous presidents, including you, and I feel like the messages were very apt and very productive for me to put a concept in my mind. And so, starting with Dr. Jackson's initiative of leadership and Dr. Sandel's of joy in medicine and yours of choice in medicine, right? So, my theory is. Um, we can deliver superior patient outcomes if we can achieve physician autonomy to a certain extent. And physician autonomy would be clearly defined by saying that a physician should be able to do what's in the best interest of a patient, irrespective of the the type of practice they are in, whether they're a hospital employed or private equity or just an independent practice or any other practice. They should really not be in a position to where they have to choose between their jobs and their duties. So, right. So that is a sort of conflict that I would like to help Pennsylvania physicians free themselves from. So my feeling, as you said, going through business school is that changing the business model in medicine can directly contribute to physician autonomy. And it can also directly contribute to patient outcomes. Because just as we are all human beings and we respond to the appropriate incentives. And if the incentive is to do good by our patients, then the business side can change that incentive. And it applies to hospital-based physicians as well, right? So one of the reasons that hospital-based physicians are under stress is because of the business leadership in their hospitals, who are simply looking at them as productivity centers, right? So if the model changes where superior outcomes can trump high volume services that are occurring right now, then their business people will also be happy, and the pressure to perform or pressure to produce will decline over time. So you don't need to see 40 patients in the day if you can get, let's say, if you can make 50% more revenue by seeing 30 patients in a day, for example, right? And the reason that is not happening right now is because we have too many middlemen siphoning off valuable dollars from the healthcare payment chain, right? So if we reduce the number of middlemen to a minimum, there will be more available healthcare dollar for the actual caregiver, whoever it is, right? So essentially, we're flattening the vertical chain by doing that. And so people would say that, how would it impact hospital employed physicians? It will impact hospital employed physicians. So they would actually be able to influence upwards towards their management chain and say, if we have a contract like this, then we can actually not struggle to produce revenue. Now, I know this because as an endocrinologist, it's very hard to generate revenue as opposed to even you, for example, for a radiologist, or a surgeon or any other procedural based specialty, right? So if we align payment models to reward high quality and better outcomes, we should be able to take care of patients when they need to be taken care of and not worry about just building up our schedule, filling our schedule in essentially. Right? I mean, that's basically what the hospitals force physicians to do, is fill up their schedules because they are collecting, cents on the dollar. And that's where the problem is. So from a business standpoint, it's very simple. If you actually get paid appropriately for the level of service and the quality of care you provide, there's no reason why access to care shouldn't improve and outcomes for patients shouldn't improve. So that's sort of my very simple, principle of connecting physician autonomy to patient outcomes.
Excellent. Excellent.